So I'm to talk about when and how to add lateral augmentation. Lateral extra-articular procedures were the ones that were practiced in the 70s and 80s, about 50 years from now, to treat ACL deficient knees or knee instabilities as they were called those days. And there were a whole host of descriptions about anteromedial, anterolateral, and several others. And people generally try to prevent the rotary instability, and they did not have access to arthroscopy or MRI as readily as we do today. And these very innovative surgeons described several extra-articular procedures. Most of them were described in 70s and 80s, but almost all of them generally failed, either in preventing instability or in preventing early onset of osteoarthritis. So much so that AAO's guideline in 1989 dissuaded surgeons from practicing this. And this brought the advent of intra-articular reconstruction of ACL and extra-articular addition at the same time. So the Jones procedures and others were the ones that were started then. However, when we look at it, the principles were nearly the same for extra-articular reconstructions. They have a tibial attachment of a tenodesis, which is anterior closer to the Gerdy's tubercle, and a femoral attachment posteriorly, which is around the lateral epicondyle, which would pretty much mimic the position of the ACL, which is intra-articular. Some of those tenodesis structures were passed deep to deep FCL and some superficial, and they were all aimed at preventing anterolateral subluxation. Lemaire in 1975 was the first to describe his, and all of these, if you look at them, were fixed, left fixed, or either proximally or distally. Almost all the time the ITB was used, and most of the time it was fixed onto itself over either through a bony tunnel or through a sling, because all the fixation devices that we had today were not available. So a modification of these procedures are the ones that we see now. Andrews was among the first to use an implant, which is a lateral screw, and both Anand Joshi and I had the misfortune of removing 3 of them. These guys did not have instability because they did not play. What happened was an intense pain on the lateral aspect. Once we took out the screws, the pain went away, and then they started to play, and later we reconstructed them. So this is another instance of ones that were just lateral extra-articular did not work. And the newest kid on the block is the ALL, which was described in the early part of this decade, and which gained a lot of popularity and then fell from popularity again pretty quickly. What do we have in present day? Even with the best of our efforts and all the refinements that we have, a fair number, or less about 10% of them still fail. And we do not know why they fail. I'm not talking about the ones where we know we fail, but there are some we do not know why they fail. And that is what has ushered a new interest in adding extra-articular procedures to the already refined way of doing an intra-articular ACL reconstruction. LET and AL reconstruction are the ones who are vying for the honor of being the most popular. And my indications, as in most people who do them, is an explosive pivot shift, which is +3, a failed ACL without any known demonstrable cause, including the slope that we have learned about nowadays, hypermobile joints, which you would consider in adolescent girls or girls who are athletes. And if you want to push the envelope, you can add ones with lateral laxity or with a femoral notch sign. The results, when you view papers, it seems to project that extra-articular augmentation with ACLR reportedly provide better rotational stability than isolated ACLR. There's lesser incidence of graft tear, which means fewer revisions. However, there's an additional scar, longer time, more implants. Whether you want to use LET or ALL, LET has been around for different variations of them, have been around for a long time. Most people are more comfortable doing one form of it or the other, and modified Lemaire's has kind of stolen the march of even Andrews or Ellison's in the United States. And that seems to be more popular with most people in literature. ALL is the newer entrant, but there are a few diehards who swear by it, and with good reasons too. A number of literature do not seem to find a lot of difference in outcome results of whether you use an LET or ALL. I'm an LET person, but I do use ALL in primaries usually in a young girl with explosive pivot without any ramp lesion. What do the literature say? It's very hard to find a randomized study, but there are two that have come close. One in 2020, which is the meta-analysis, which seems to say, with advances in reconstruction techniques, combined reconstructions are found to be effective in improving rotational stability and to lead to good functional scores. However, it is not suitable for all comers, and you have to choose an a la carte principle. And this is a systematic review of meta-analysis, and this is a randomized controlled study in 2023. And they seem to say that lateral reconstructions can be considered as reinforcement to ACLR to improve anteroposterior and anterolateral rotational stability of the knee and reduce the risk of failure. And this is how I do them. A very short lateral. I do a modified Lemaires, remove the about a 10 centimeter of 1 centimeter wide iliotibial band, pass it under the FCL, reroute it under the FCL, and attach it to a tunnel proximal and posterior to the lateral epicondyle, usually with a swivel lock, or we could use any of the devices. And the post-op regime, there's not much difference between ACLR and ACLR with LET, except in revisions where I go a little slow. Thank you very much.
Thank you, Dr. Bhattacharya.